Over to you, Dr. Rajesh.
At the onset, I like to thank organizing committee for inviting me to deliberate on this topic. SGLT2 inhibitor unplugged. Know anything and everything. Although topic looks quite attractive, but to be honest, if I try to cover this topic, it will be not less than a day because SGLT2 inhibitor is one molecule where every week one paper will come out with some new information. And 20-minute time is a too small time to unplug each and everything. So me and Samit, I believe we are going to do something which is known to you. So we are going to revise that and something which you do not know. So we are going to have a mix of that. This is what I am going to discuss. But even if I discuss 13 points in detail, I'm not going to finish in 20 minutes. So I am going to skip some of the things, will highlight on important things, and then rest of the things we can take up during discussion and Q&A session. Now, what is the goal of management of diabetes? Now, this has undergone a transitional change. When I was student, we were only focused on achieving fasting plasma glucose, postprandial glucose, and HbA1c. Even HbA1c targets were not defined in those days. And then, with advent of UKPDS trial, DCCT trial, we come to know about importance of HbA1c, minimizing risk of hypoglycemia, issue of weight gain. VADT advance told us further. But then, over last 10 decade, with advent of CVOT trial, we have now started talking about achieving long-term goals, which is preventing cardiovascular mortality, preserving renal function, and managing comorbidities also at the same point of time. So as you see, diabetes is not now management of glucose. Diabetes is actually management of a metabolic disease which include your hypertension, dyslipidemia, obesity. Now obesity is coming in forefront everywhere, like SGLT2 has come in forefront, and then managing all the associated issues which may be present, which may not be present at the time of diagnosis of type 2 diabetes. Now, what should be an ideal drug for type 2 diabetes? Again, debatable things. That's why so much research has happened and the treatment of diabetes has become complex. When we were students, some of you who are senior to me were students, one or two drug, one insulin, no complexity, सबको वही लिखो. डायबिटीज के बारे में कोई कॉन्फ्रेंस भी नहीं होती थी ज्यादा. Now 10 different class of oral drug, 5 different type of insulins. So that's how this confusion has started. If we see the properties of an ideal treatment, this is all which should control both fasting, postprandial, 24-hour duration of action, glucose-dependent insulin secretion, suppresses glucagon, free of risk of hypoglycemia, weight loss, weight neutrality, sustainability, cardiac, renal, and other extra glycemic benefits. Probably none of the drug fulfill all the features, but two new class of drugs, which are SGLT2 inhibitor and GLP-1RA, they try to fulfill large number of them, and that is why the entire paradigm shift in management of diabetes has happened, and all the new guidelines are actually discussing now these two agents, and I am going to discuss actually SGLT2 inhibitor with focus on dapagliflozin. Now, again, before I go to DAPA and SGLT2 inhibitor, this is a very interesting data. You know what is a residual risk when we were treating diabetes with conventionally available agents to us many years back? You see the risk of HF, residual risk, 100%. Residual 3-point MACE, 91%. MI residual risk, 85%. And some of them are actually more than what patient treatment has been started. So actually all these issues are never addressed by the type of therapies which we have used in the past. Still we are using them. It is not that we have stopped using them, but then the newer therapies has to be given to all patients of diabetes early in the natural course rather than waiting for one of the complications to develop and then to start these newer forms of therapy which include SGLT2 inhibitor and GLP-1RAs. Now coming to SGLT2 inhibitor, what is their effect on glucose? Now again, this is a very important question because sometimes company people will say, my drug will cause HbA1c loss of 1.5%. Now this is not so actually in truth. Whenever somebody claims their HbA1c, always look at baseline HbA1c at which this drug is started in that given trial. Now, even for SGLT2 inhibitor like dapagliflozin, as you see, if the baseline HbA1c is more than 9%, up to 1.3% reduction in HbA1c is seen. But if your baseline HbA1c is close to 8%, on an average, SGLT2 inhibitor causes 0.7 to 0.8% reduction in HbA1c, not more than that. So as you see, as compared to metformin, as an add-on to metformin, there is significant decline in HbA1c with use of this. Now, the next important issue is sustainability, because there is a concept of secondary sulfonylurea failure. Natural history of diabetes progresses, and there is an inexorable loss of beta cell function. So the drugs which are effective today might not be effective 2 year, 3 year, 4 year down the line. Now with SGLT2 inhibitor, at least we have 4 year data at which they have shown, and as you see in this curve very carefully, this is as sulfonylurea. There is a brisk initial decline in HbA1c as compared to SGLT2 inhibitor. But then as we go towards 4 year, there is an issue of secondary sulfonylurea failure. The lowering of HbA1c achieved with SGLT2 inhibitor is sustained, maintained up to 4 year. So these are some of the differences between drugs we were using. Then the next important issue and benefit with SGLT2 inhibitor is loss of body weight, because there is loss of glucose into the urine, and each molecule of glucose is equivalent to 4 kilocalories of energy. So if you are losing on an average 80 to 120 milligrams of glucose per day, you multiply it by 4. That is the amount of calorie actually which you are losing through your urine. And because of that, there is loss of body weight. Now, this is a welcome advantage. We always ask our patient to lose weight nowadays in diabetes. And in the, again, trials, it has been shown that on an average 3 to 5 kg loss of body weight is observed with use of SGLT2 inhibitor, dapagliflozin. Here is our data, and this weight loss again is sustainable. In contrast to some of the commonly used drug where there is a weight gain with use of anti-diabetic agents. Now the next question is whether everyone will have similar type of weight loss. Can we use SGLT2 inhibitor in those who does not have obesity? Now, first of all, we have to understand definition of obesity in Asian Indians is different as compared to Caucasian population. So even at a BMI of 23 and 25, it is overweight and obesity for us. But then when we see as compared to BMI, similar to what is happening when we are talking about fall in glucose with HbA1c, higher is your baseline BMI, more will be the fall in weight. But the drug is effective even in those who are overweight and obese, and even by Asian cutoffs, if we see between 25 to 18, it will show beneficial effects in body weight. Now, whenever we are talking of body weight, this is a very important question because lots of obesity session might have happened in Diabetes India also. What type of loss of body weight is going to happen? Now, nobody wants to lose lean muscle mass. But always remember, whenever you lose your body weight, by whatever means, whether it is drug, whether it is exercise, diet, your therapies like surgical therapies, it is actually some degree of lean muscle mass is going to be lost. So you have to take exercises like resistance exercises, increase your protein intake so as to preserve your muscle mass. Now with SGLT2 inhibitor, this is the cross-sectional diagram of the skin. It has been shown that the predominant loss of weight is because of loss of visceral adipose tissue. Now visceral adipose tissue is culprit in patients of diabetes and metabolic diseases. So therefore it's a welcome thing that with use of dapagliflozin, there is loss of visceral adipose tissue. Now, another beneficial effect is on blood pressure, and that too when patient is already on background of ACE, ARBs and other antihypertensive therapies. Despite being on background, when we are adding these drugs, there is a beneficial around 4 to 6 millimeter fall in systolic blood pressure, around 1 to 2 millimeter fall in diastolic blood pressure. Although these number looks very small, but then even this small fall is impressive when we translate them into reduction in long-term outcome. Risk of hypoglycemia, as I have told in the initial. Now, if you compare it with sulfonylurea, there is a marked reduction in risk of hypoglycemia as with dapagliflozin. So, the two drugs, DAPA means SGLT2 inhibitor and GLP-1RA, if we are using in combination with metformin and other insulin sensitizer, probably there is no risk of hypoglycemia. If you are using on the background of sulfonylurea, insulin therapy, your HbA1c is coming down, then probably it's time you should reduce the dose of sulfonylurea or insulin. Otherwise, patient is bound to develop some degree of hypoglycemia, and the wrong blame will go on to the newer drug, that the new drug is so potent that the patient is going under hypoglycemia. Now, cardiovascular. What about heart failure? Now, this is a very important area which has not been addressed before advent of SGLT2 inhibitor, heart failure in diabetes. So, what is role of SGLT2 inhibitor in heart failure? Now, recently, past 2 years, heart failure has been classified into heart failure with preserved ejection fraction, with reduced ejection fraction, and mid-range ejection fraction. In past, it used to be diastolic dysfunction and systolic dysfunction. Those terms are not used. Now, this is European Society of Cardiology statement, where irrespective of type of heart failure, whether it is preserved, reduced, or mid-range, SGLT2 inhibitor with special emphasis on DAPA and EMPA, both are now class 1A indication, which means until and unless contraindicated, all heart failure patient, irrespective of their glycemic status, should receive SGLT2 inhibitors. And that is why these drugs are now so popular even among their cardiologist colleague, and they have started taking that diabetes is now our disease. So this is the drug which has to be used. Now, where is the evidence? Now, if we come to the evidence, now there are two important trials with dapagliflozin, DAPA-HF trial and DELIVER trial. If you see for heart failure with reduced ejection fraction and outcomes in terms of CV death or worsening of heart failure, there is 26% relative risk reduction. NNT is 21, which is quite impressive. And the time to response is day 28. By day 28, beneficial effect of dapagliflozin appeared. If we look for heart failure with preserved ejection fraction, an entity where we do not have much of the effective therapies, here again, there is an 18% relative risk reduction. Number needed to treat is 32, and the benefit time to response is as early as day 13. That is why I'm saying no heart failure patient should be devoid of benefit of SGLT2 inhibitor until and unless we cannot give because of side effect or some contraindication. Now, if we combine both DAPA-HF and DELIVER trial, because it can be used irrespective of your ejection fraction, you will see 3-point MACE. The relative risk reduction is by around 10% and absolute risk reduction is around 1.3%. If we see the effect on death and CV death, 14% relative risk reduction and hospitalization for heart failure by around 29%. But then some of you are going to ask me the question, which to be used? Empagliflozin is to be used or dapagliflozin is to be used? So if we compare both the molecules together based on the trial evidence available to us, with EMPA also we have EMPA reduced and other outcomes. If we see heart failure with reduced ejection fraction, the reduction in CV death and reduction in all-cause death is seen significantly lower with dapagliflozin by 18 and 17%. There is a reduction in CV death and all-cause death with EMPA, but it failed to show statistical significance. So this is the difference. There is a numerical lowering, but it failed to show statistical significance. When we see across EF, when we forget our ejection fraction, again reduction in CV death and reduction in all-cause death, it is 14% and 10% respectively. But again, there is a numerical reduction with EMPA, but it failed to reach statistical significance. So it's totally up to you which molecule is to choose. This is the data which is available to all of us. Coming to CKD, another important comorbidity which is present in patients of diabetes. Now, this is latest KDOGI guidelines, where again they have recommended that all patients of diabetes whose eGFR is more than 20 ml, who have microalbuminuria, they should receive SGLT2 inhibitor again until and unless it is contraindicated or we cannot use because of side effects. Now, if we see dapagliflozin per se, which is DAPA-CKD trial, one of the largest trial involving large number of patients, the primary composite endpoint is sustained eGFR more than 50% reduction, progression to ASRD or CV death. Now, you see primary composite endpoint is achieved in 39% relative risk reduction. And again, see the NNT. NNT is a very important term. to highlight the importance of a drug in a particular disease. It is only 19. Again, very impressive. All cause mortality, 31% relative risk reduction, composite of CV death or hospitalization for heart failure. Because all patients of CKD usually die because of cardiovascular disease. Now, relative risk reduction is 29%. When we try to look and dissect the data according to the glycemic status, that is normoglycemia, pre-diabetes, and diabetes. Now, irrespective of glycemic status, both primary composite endpoint and all-cause mortality is significantly benefited by use of SGLT2 inhibitor, dapagliflozin here. What is most important is maximum benefit is seen in pre-diabetic population, which is actually a huge number, huge number. And again, the question, when we compare it with empagliflozin, DAPA-CKD and EMPA-kidney, these are the two pivotal landmark trials which have changed the scenario for use of SGLT2 inhibitor. Now, if we see, it is reduced by 39% relative risk reduction with dapagliflozin, 28% by empagliflozin. And NNT, what was the NNT with DAPA? 19. I have told you in previous. So it is 19 and NNT with EMPA is 27. So both are good, but there are slight differences. Key secondary endpoints, all-cause mortality, composite of CV death or hospitalization for heart failure, they are significantly reduced by dapagliflozin to the tune of 31% and 29%. Also, they are reduced by EMPA by 13 and 16%, but again, it failed to reach statistical significance. So these are small differences between the two molecules. So I am actually cut shorting large number of questions which were going to ask me at the end, which molecule is to be used. Now moving from that and seeing patients who are only having albuminuria, a large number of population does not have derangement in creatinine, but they are coming to us with micro or macroalbuminuria. Now, when we see according to progression from micro to normal, macro to micro, as you see again in this forest plot graph, with use of dapagliflozin, there is significant advantage. And new drug has also come up, which is finrenone, which should also be used in patients of diabetes with macroalbuminuria if the desired results are not achieved well in time. Now, next important issue is what is the impact of SGLT2 inhibitor in new onset of diabetes in patients with cardiovascular disease or kidney disease. So patients are having, we know now, cardiologists are using irrespective of glycemic status, nephrologists are using irrespective of their glycemic status, but then whether these patients are going to develop new onset diabetes, that's a very pertinent question. Now, in DAPA trial program, it has been shown, as you see in this curve, with use of dapagliflozin, there is 33% relative risk reduction in new onset diabetes in patient of cardiovascular disease and kidney disease who at baseline did not have diabetes. So this is preventive aspect of using SGLT2 inhibitor, specifically in patients who are having cardiovascular disease and kidney disease. Lastly, safety issue. Now this is very important because we are going to use elderly patients and large number of population. So here the entire data is clubbed from Declare, DAPA-HF, DAPA-CKD, more than 26,000 patients. And as you see the side effects like fracture, volume depletion, renal adverse event, amputations, diabetic ketoacidosis, there is not much of the difference as compared to placebo, but we have to understand, yes, there is some small side effect risk, but I always say this thing. Patient often ask, but I'm surprised when physicians ask, see if there is a drug which does not causes any side effect, then probably you and me are not needed. There will be no CME program. Patient will search on the Google uncle and will purchase the drug from the market. So we have to find out a right patient. We have to educate the patient about the side effect and we know how to manage those side effects. So when we talk about SGLT2 inhibitor, there are small differences, but when we compare it with placebo, the drug is safe to be used in large number of patients. The important issue is regarding risk of UTI and GTI. Now, when we talk about GTI, that is genitourinary tract infection, no doubt. The risk of genitourinary tract infection as compared to placebo, as compared to DPP4 inhibitor, as compared to your other drugs like sulfonylurea is high. When we take about the risk of UTI, it is comparable. But then we have to remember these risks are that it is caused by similar organism, easy to manage, and most of the patient overcome these side effects. But if somebody is developed recurrent UTI or recurrent GTI, two or more than 2 or 3 episodes, then probably it makes a case where we should not use this drug in a given patient. Before I stop, we should look for 2025 recommendation again, because this question is often asked, what about newer recommendation? So this is ADA 2025. Now what ADA 2025 says, whenever you see a patient, risk stratify from cardiovascular and renal risk point. And anybody who is a high CV risk, what is that high CV risk? More than 55 years with 2 or more additional risk factors like hypertension, smoking, dyslipidemia, albuminuria, obesity. It makes a case to start SGLT2 inhibitor and or GLP-1RA. If patient is already a case of atherosclerotic cardiovascular disease, heart failure, again it makes a case to start SGLT2 inhibitor oblique GLP-1RA. Here, a very important message, choose a drug which has been proven for these benefits. There are generic versions, there are drugs which has not been tested. We should not debate for that some drug is cheaper, but since the drug has not been tested, we do not know whether the drug is going to benefit. So the drug with proven benefit in outcome trials should be used preferentially. And then for CKD, SGLT2 inhibitor are drug of choice, but with a recent trial with GLP-1RA, GLP-1RA should also be added on in all such patients where we have not achieved our desired goal. Lastly, we often talk to all our patients lose weight, hypoglycemia. These are the drugs which are to be used. So to friends, to conclude with, this is what I have discussed with you. Multiple CV risk factor, heart failure, CKD, cardiorenal, and blah, blah, blah. And if you see probably across entire spectrum of disease, SGLT2 inhibitor can be used. I have shown you data from number of clinical outcome trials. Based on that, SGLT2 inhibitor probably is a class 1A indication at majority of places, and DAPA is one of such SGLT2 inhibitor which has been used extensively. Thank you.